Oh, wow. Look at how short I am back here. Hi, everybody. Good morning. Can you hear me okay? All right. Good. Those in the back, you can hear me as well? Good. I'll try not to wander away from the mic too much, although it's tempting because I feel very short behind this podium. My friends won't have the same problem. So we're going to talk about the spine this morning and really how the spine is important, of course, to function, and how some problems with the spine can imitate symptoms of post-polio and sometimes be confused. So if you have any spinal problems, it's good to have a good understanding of what's related to spine and what it isn't. The spine itself, of course, is sort of the basis of our trunk. It extends from the base of the skull down to your tailbone. It supports the trunk, the rib cage, stabilizes the limbs, and protects the spinal cord, which is the extension of the central nervous system from the brain down to the upper lumbar spine, and from the spinal cord extend all the individual nerve roots. The spine also has multiple segments, 33 in total, and all of those segments have some degree of motion, which is what allows your trunk to move in multiple different directions and really function as you are moving in space. Here you can see where the nerves exit. We have a number that exit in the cervical or neck area. Those are the nerves that go to the different muscle groups in the arms. You have thoracic nerves. Those just are one per level and radiate around the trunk. And then in the lumbar sacral area, you have nerves that extend, interact, and go down into the lower extremities. You also have at the very, let's see, I don't know that I have an arrow here. Anyway, at the very top of the spine, the cervical nerves that come out, that go to the face and neck area. So within the spine, you can see the bones here on, it would be your left side, that protect the spinal cord is that runs down the middle of the canal of the bones. So it's well protected. It's also surrounded by a sac of fluid. It is within the spinal cord where the motor nerve nuclei live. That's like the cell body of those nerves, and that's where polio affected the spinal nerves. It kills off those anterior horn cells, we call them. The muscles that support the spine are your trunk muscles, and you have multiple layers of muscles in your trunk, from small muscles between each individual segment of the spine to long ones that run almost the entire length of the spine. You then have different oblique muscles that overlap that allow the rotational and bending movements. When you had polio, when the virus gets into the central nervous system, it attacks that cell body of the motor nerves within the spinal cord. And because of that virus getting in there, some of those nerves die. And as a result, muscles lose part of their innervation, part of the cell that's sending signal to the muscle tissue, and you result in a muscle that's either working partially or possibly not at all. Because the effect of the virus within the central nervous system is pretty random, you get a very asymmetrical result of loss of muscle and skeletal or spine support. Once you lose muscle tissue, the growth of the spine and of other bones may be affected. Part of what causes bone growth as we are developing as children is the tension of muscles on the bone. So if you've had polio with paralysis, the effect on the spinal column itself can be loss of bone strength. The bones may not have developed as strongly as they would have had you not had loss of muscle tissue. Body mechanics are often altered, and the support of the spine not as complete as it would have been. If there's asymmetry in the levels involved, you can get a secondary curvature like a scoliosis with a deformity of the spine. And along with that, with the asymmetry, there's going to be increased stress on certain levels. You won't have the smooth, symmetric motion that the spine normally has. It also, because of that asymmetry, will put stress on the supporting tissues, the muscles and the ligaments that are still intact. So in a polio survivor, we can see a number of different spine problems. These include the spine deformity, can be osteoporosis or loss of bone density in the spine. And because of those asymmetries, we see accelerated degeneration. Now, most people get degeneration in their spine as they age. Can start very early depending on what you do. Because the spine is so movable, there's a lot of different stressors that can start a degenerative process that I'll describe in a minute. The degeneration and the secondary effects can then result in nerve impingement. And some of those nerve impingements or loss of nerve function can mimic post-polio. When we talk about spinal deformity, it's often an exaggeration or alteration of the normal curves of the spine. We normally have what we call a little bit of lordosis in the neck, or the neck curves forward a little bit. The upper back curves back a little bit, the low back forward again. But those curves can be exaggerated if muscles are not weak. They can also be exaggerated sometimes when there's poor posture or bad habits, and Dr. Wise is going to talk more about posture along with me later in the day. The other thing that can affect spine deformities are contractures. And contractures are when a muscle shortens and it does not allow the full length of motion. Contractures are not as common in polio as some other conditions that cause increased tone, but they can occur in polio survivors where there's an area where a muscle is intact, the muscle that does the opposite action is very weak. And when you have an unopposed force like that, the stronger muscle will tend to shorten. So we can see increased thoracic kyphosis, increased lumbar lordosis, or that curve to the side, as you saw on the previous slide, of scoliosis. The risk of scoliosis in a polio survivor is about 30%, and that's due to the asymmetric weakness of the trunk muscles, abdominal muscles, intercostal muscles. Can also be due to pelvic weakness or tilt due to a leg length difference. So if the pelvis is always tilted, the spine is going to compensate by curving to the side and trying to correct that. Our bodies try to maintain us as upright as possible and get that head centered back over the pelvis for the most stable standing and gait. Progression of a curve is correlated to the degree of weakness and the age that the curve started. We're always concerned about progression of scoliosis or other spinal deformities during the growth years. So some of you may have had spine fusions when you were young, because as the body is growing very quickly, those curves can progress very rapidly and cause secondary problems. The growth, once growth starts, stops when you're an adult, those curves progress much less slowly. And a very mild curve will really not progress much at all. But a more severe curve, because there is so much uneven stress through the segments of the spine, does continue to progress. And sometimes we do recommend surgical fusion even in adults. The scoliosis, as I said, there's a dramatic risk of increase during adolescence when the growth is the fastest. The result of a severe scoliosis can be reducing lung capacity. You often, as is illustrated here, you can see that the lung on the left side, where the little L is above the shoulder, is going to be compressed significantly, can't expand, and that reduces your pulmonary capacity. Also, when scoliosis is pronounced, there are a lot of bony pressure points that occur because you can have ribs that protrude, you can have a shoulder blade that protrudes, but this results in pressure points when you're sitting or lying down. The progression once you're an adult is due to degeneration in discs, can be due to compression fractures of the actual vertebral bones, or lateral slippage of the vertebra, which also can happen as discs degenerate and ligaments get looser. This progression of the curve often will result in pain, in impingement of nerves if it's to the extent it's used up the space around the nerve. It can also result in an unbalanced spine. So as I said, normally the body will try to compensate, and we often see in somebody with a scoliosis two curves, one to one side, one to the other side, to get the head back over the pelvis. But as curves progress, they become unbalanced at times, so that you're listed over to one side and can't straighten up. And again, we talked about the reduced lung function. Osteoporosis in the spine and in areas of your body where muscles were significantly affected by polio, so there wasn't a lot of muscle tension on bones, we know that there is reduced density of bones. They haven't progressed to the normal density at skeletal maturity. And everybody reaches their peak bone density in their early 20s, and then it slowly declines from there. So whatever your peak is determines how soon you develop what we term osteoporosis, because as the bones slowly get weaker, at a certain critical level, we term it osteoporosis, which means there's increased risk of fracture. So you can, when a bone becomes very weak, you can have compression fractures. And those can occur with trauma, but they can also occur spontaneously if the bone is very weak. I messed this slide up. Anyway, so polio survivors are at increased risk because of the reduced peak mass, the reduced action on bone, and if your mobility is reduced, one of the things that maintains bone density as an adult is activity and putting stress through those bones. Bone is an active substance in the body that continues to remodel, but the less you stress it, the weaker it gets, just like with muscles. So, as we get vertebral compression fractures, it may increase those curves. And I'm sure all of you have seen, because osteoporosis is more common in women, older women that have become more and more bent forward due to compression fractures. Spine degeneration, as I said, is very common in the general population, but because polio survivors have more stress on the spine from the asymmetry, this may be accelerated. And as degeneration occurs, those spinal curves can also progress. Degeneration in the spine can start with degeneration in discs. If you look at the spine from the side here, you can see the bones are there with joints at the back of the spine. In between each bony segment is a disc that serves as a shock absorber and allows motion at that area. The discs take a lot of stress, especially the ones lower in the spine that are carrying a lot of weight, and degeneration occurs, as I said, in most people as we get older. Once there is degeneration in the discs, we also start to put more stress on the joints and develop arthritis or degeneration in the joints. So often we see both. One of the things the body does to try to stabilize that degeneration is form these little osteophytes or bone spurs that try to stabilize the spine and can progress to the point it actually autofuses levels together. But that doesn't always happen, and sometimes as it's happening, those osteophytes or bone spurs start to impinge on nerves and cause secondary problems. So when the joints degenerate, it allows slippage of the vertebra, and that can be forward, backward, to the side. Those joints start to enlarge because they are now developing degeneration and arthritis themselves. So that slippage of the vertebra, enlargement of joints, bulging discs, all take up space within the spinal canal where the nerves run. So it can result in nerve compression. When we have nerve compression at a single level, it leads to pain in a specific distribution. So the common levels involved are here, and you can see that probably the one people think of most commonly as sciatica is the S1 nerve root that goes down the back of the leg to the foot. But you can also get other nerve levels involved where it's more the side of the leg into the anterior thigh. And you can see because that pain runs through some major muscle areas, if you have pain in that area, it may be difficult to tell whether that is nerve pain from a nerve impingement in the spine or muscle pain from polio. The pain due to nerve compression can be constant, but is often intermittent and related to position or activity. The narrowing in the central canal of the spine is called spinal stenosis. A lot of you have probably heard the term stenosis from coronary artery stenosis. Stenosis simply means narrowing. In the spine, when you get narrowing in the central canal, it will compress multiple nerves at the same time, and it's not as specific to a certain nerve root distribution. And this is often comes on very gradually and progresses often slowly, although at times it can come on very suddenly. The symptoms of spinal stenosis are very similar to those you may have from post-polio. In the neck area, stenosis, the first symptom is often loss of balance and problems with tripping or stumbling. In the lower back, you get pain in the legs or buttocks that's usually described as a deep ache that's worse with standing or walking. So you can see how that could certainly be confused with polio muscle pain. The difference is in stenosis, there is often also more of a nerve type character to the pain where people may develop a burning or crawling or tingly sensation. And typically in the earlier stages of stenosis, pain is alleviated with sitting. The other thing that would differentiate spinal stenosis leg pain from polio pain is that it tends to be worse with standing than with walking. And that's because of the position of the spine and the amount of blood flow you're getting to the nerves. When you're standing still and you're the most upright, that space is the tightest. As you start to walk, you have more blood flow going to the area. You tend to bend forward just a little bit. That opens up that space. That opening up the space with bending forward is also why the pain is usually relieved with sitting, or better if you're walking with a walker or a shopping cart. The other thing that often will differentiate spinal stenosis pain from either polio or vascular claudication, which you can get pain in the legs if you don't have good blood flow because of vascular disease. But with stenosis, going uphill because you have to bend forward more is usually easier than going downhill where you have to go into more spine extension, which for a vascular condition or polio, because there's more energy involved and more work involved in going uphill, that'll be the worst direction to go. Spine degeneration also can lead to back pain, leg pain or weakness, loss of sensation in parts of the leg, change in bowel or bladder control, difficulty breathing if it's a higher level, increased fatigue, increased loss of balance, increased frequency of falls. So you can see there's a lot of overlap with what you experience with post-polio. Spinal disorders, though, are more treatable. If we can identify the area where there is impingement or nerves, or what is the pathology causing it, there are treatments that we have available. I'm not going to go into the therapy approach because Cynthia and Kat will be doing that in a minute, but we also use medications, bracing much less commonly than for polio. There are injection procedures that can help, and often injection procedures are a good tool to differentiate if it's not clear if you're having leg pain and is it due to the spine or is it due to polio. If an injection in the spine alleviates the pain, obviously that gives us an indication it was a spinal cause, not polio. When it becomes very severe or nerves start to lose function, there is also surgical intervention that can help with that. So pain medications that I use for spine disorders are usually effective for the arthritic component, where we use things like anti-inflammatories or Tylenol. And you know we have to be careful with how much of those you use, so it has to be in moderation. If pain is very severe, I will use narcotics at times, but usually only for an acute change or an acute condition, because long-term narcotic use is very problematic, usually requiring increasing doses and then secondary problems with less alertness, fatigue, constipation, and so for a chronic condition, we try to stay away from narcotics. Narcotics are not especially good for spine or nerve pain anyway. If there's a lot of nerve kind of pain, we usually use what we call neuroleptic medications. Most of these were originally developed as anti-seizure or anti-depression medications, but they work more specifically on nerves and stabilize nerves. They also, though, because they work in the central nervous system, can cause drowsiness or a spacey kind of feeling. So a lot of times we try to use external means of controlling spine disorders or spine pain. So it may be bracing if the pain is specific to certain positions or motions, bracing to reduce motion or keep you in a certain position can provide a lot of comfort. So if you're pretty comfortable sitting and lying down, but as you get up, your spine isn't real stable and it gets into positions that are painful, using a spine orthosis may be very helpful. They do tend, though, to be very difficult to sit in, because once you sit, they start to dig into your chest and groin area, and so they're often useful mostly for when you're up and around and doing different activities. The good thing we know about it, though, is they don't cause you any harm. You know, if it's uncomfortable, you take it off. It's not like a surgery that's irreversible. Injections also can be helpful if there's an inflamed nerve. Putting steroid around the nerve sheath can reduce that pain significantly. We have a procedure where we block the sensory input from joints when they're very arthritic, and that can alleviate a lot of pain. But with all the injection procedures, the relief is temporary, and you have to weigh the pros and cons of, does getting a few months of relief, you know, is that worth going through the procedures? And often I encourage people to maybe give it a try one time, see how much relief they get and how long it lasts, or say you have a big event coming up, and it may be worth doing one of those procedures so you have more tolerance and less pain for that specific event in your life. As I said earlier, if there's a really loss of function of nerves or the spine is very unstable, then we send people for surgery. And I'm not going to go into the risks of surgery. You all know the risks involved in anesthesia. Often these surgeries are big surgeries, although at times we can do a single level decompression that is a relatively short procedure. So our preferred management is really modalities, topical medications, change in lifestyle and activity. Does that sound familiar? So like with a lot of the other things we manage in post-polio, we do the same thing with spine conditions. So I'm going to hand it over to the physical therapist here in a minute, but I want to summarize by saying that spine problems in polio survivors are very common. And these common problems include spinal deformity, osteoporosis or reduced bone density, degenerative changes, and nerve compressions that can develop. These symptoms can be confused with symptoms of post-polio syndrome because you see new weakness, more fatigue, leg pain with walking that's relieved with rest, and you can see increased difficulty breathing. I'm just going to add in there, though, often with a spine nerve compression, you also see loss of sensation. And that's something that you never see due to polio because the polio virus only affects nerves to muscle. So if you are getting an area of a limb or of your body that is becoming numb, that you can't feel, you certainly want to go to your doctor and ask about possible spine problems. Our treatment options include medication, racing, injections, surgery in the most extreme cases or when there are specific indications, and then the mainstay of treatment is really physical therapy. So I will now pass it on to Cynthia and Kat to talk about the therapy. Thank you.
Good morning. It's
Yeah.
Oh,
No, gotta get the file.
do you just click on?
Go to slideshow.
Right there?
Here, I'll get it.
Just that?
Thanks.
You can start talking, right?
Good morning. Cynthia and I are very happy to be here, seeing old friends and new. And now that Dr. Vandenakker has discussed the anatomy of the spine in detail and many of the conditions that can occur, Cynthia and I would like to explain the physical therapy techniques that can relieve the pain and dysfunction associated with this. Physical therapy typically involves and should involve a multifaceted approach. No two spines are the same. Even if it is the same spinal diagnosis, everybody has to be treated with an individual treatment plan. Physical therapy interventions address the changes in the body that occur due to a spinal diagnosis, and we use modalities to address symptoms, body mechanics and ADL modification to decrease the stressors on the spine, therapeutic exercise to improve the supported structures so that everything is working in tandem to alleviate stress on the body. Changes that occur in the spine have been well outlined by Dr. Vandenakker, but just to review, you will get a loss of, naturally in the body as we age, you get a loss of disc height, which is the cushion between the vertebrae. The vertebral body's thin due to a loss of mineral content, and bone spurs and arthritic changes can occur. As a result, the trunk becomes shorter, and that leaves less space for lung capacity and internal organs. So physical therapy can alleviate some of that discomfort through positioning. Dr. Wise will be discussing postural changes and some remedies in that regard. And one thing I didn't want to ignore is breathing techniques and diaphragmatic breathing, because oftentimes people get into a hurried lifestyle. With this decreased lung capacity, there can be just use of the upper respiratory muscles, and we want to return to nice deep breathing techniques that are more efficient and effective for the body. Okay, I'm going to discuss the treatment modalities that physical therapy utilizes for pain control. Those include ultrasound, electrical stimulation, heat, cold, and massage. The benefits of modalities are to decrease the pain, decrease inflammation, improve blood flow, and relax muscles. Each modality has certain indications and contraindications based on the patient's medical history, and it is determined after a thorough evaluation, what is appropriate for each patient. I like to tell people that modalities in and of themselves are not the fix. It is usually a preparatory process to get you ready for treatment intervention like flexibility exercises, strengthening where appropriate, and different positioning. So in the modalities, we utilize the application of moist heat oftentimes. This accelerates the metabolic process within the cell. It increases circulation to flush out the waste product of a muscle contraction if you're having muscle spasm or trigger point tenderness. It can reduce pain, and it promotes relaxation because it's very soothing in its application. Local cooling, on the other hand, helps to decrease inflammation by decreasing the metabolic process to the tissue. It promotes an analgesic effect by decreasing nerve conduction and muscle contractibility. It also helps to decrease muscle spasms. However, a lot of people with a history of polio are very intolerant to cold. So we don't tend to use it as our first go-to. However, oftentimes if there is like a tendinitis that we feel it's important to use cold, Cynthia and I have found that if we place the cold pack, say on the shoulder, and then put moist heat adjacent to it, it is much more tolerable and the patient can get through the application of cold. Okay, modalities also include myofascial release and soft tissue mobilization or massage. Basically, the fascia is a connective tissue that surrounds the muscle groups and muscle fibers, and it can even surround the circulation or the vessels. You may have heard of trigger points, and they are essentially like a knot in the muscle that is a spasm of a small patch of muscle fibers. And so you can reach back and actually feel sometimes on your shoulder that there's a little nodule, and those are considered trigger points, not to be confused with a cramping of a muscle or a Charlie horse. So basically we use soft tissue mobilization to increase circulation to the area. It aids in the reduction and release of muscle spasm. It allows stretching of abnormal fibrous tissue, or the fascia sometimes. It increases extensibility of the soft tissues. It can promote endorphin levels, increased endorphin levels, and it is generally relaxing and gives a sense of well-being. Most everybody loves a nice massage. Okay. Okay. Ultrasound is not the kind of ultrasound that most of us think about in terms of projecting the image of a fetus. What we're talking about, a therapeutic ultrasound, which uses sound waves to treat and promote healing. There are two types of ultrasound. A continuous ultrasound would increase thermal effects within the tissue. It promotes healing by increasing the metabolism of the cells in the soft tissue. And I like to utilize the thermal effects before I do, say, a soft tissue treatment to get the circulation flowing and then move on to the next. Now, the mechanical effects are used in pulsed ultrasound, and this provides a micromassage deeper in the tissue without the thermal effects if it's contraindicated. And these treatment techniques would be determined to be appropriate by the physical therapist and the physician. They can decrease inflammatory responses and tissue swelling. Electrical stimulation is utilized also for decreasing pain, and it sends electrical impulses into the skin to the underlying nerve fibers, and it works in two ways. One, it can block the painful signals getting to the brain, so it's kind of a diversion. And the other way is, depending on the settings, it can create a release of our natural analgesics, which are called endorphins. And they are chemicals in the brain that can be released to help with pain reduction. This should not be confused with electrical muscle stimulation, in which the stimulation is used to contract the muscle tissue, and we do not use that with polio patients because we do not want to over-fatigue the already weak muscles. Okay, I'm going to pass it over to Cynthia for a minute.
part of your physical therapy treatment we're going to talk about is the therapeutic exercise. And therapeutic exercise are physical activities to improve your function, to correct an impairment, obtain a state of well-being, or to restore strength, endurance, flexibility, stability, and balance. To properly prescribe an exercise program, your physical therapist must do a complete evaluation, and this includes your medical history, a physical assessment, and an individualized muscle test. This also will include, the physical assessment will include the way that you move, your sensation, flexibility, strength, etc. The reason that this is so important, we'll get into a little, overall, but I need to know prior to setting up the exercise program what is weak, what is strong, which muscles I can have you exercise with, and then also with the muscle test, I may be able to figure out or help determine, are some of these muscles weak because of polio? Or are some of these muscles weak? Are they new weaknesses that may be associated with your spinal deformity or spinal dysfunction at the time? So the objectives of the therapeutic exercise, first is to assist the body in reducing the pain and the inflammation. And then after you've come to a little bit more of a steady state, we get into improving range of motion, increasing muscle strength, and increasing muscle endurance. Now we know that exercise can be a real challenge for people who have had polio, but we must balance out the overuse and disuse. Okay, you can't sit all day, not exercise at all, and expect those muscles to get stronger and support you. Again, the exercise program is going to be tailored to each individual's muscle test, and we're only going to strengthen with muscles, with the extremities that can move against gravity. This gets into more the exercise guidelines that I'll go over very quickly. But you want your therapist to know those exercise guidelines. They are in your handouts. We did put them in there, and make sure that you share them with your therapist so that they're aware of how to help you exercise. And also avoid excessive fatigue. So I'm not going to go over those exactly, but just in general, muscles, and this is in the literature, muscles that are grade 3 out of 5 or less should be protected. These are the muscles that can only move against gravity to a certain level but cannot take any resistance. As we get stronger, if the muscle can take a small amount of resistance, it can be exercised with caution. More resistance can be exercised moderately, and then a strong muscle can be exercised more vigorously. When you're exercising, you should experience a mild fatigue. Okay, so if you're going to work, go to therapy, or you're going to do your exercise program, and you have to come back and take a short rest period, that's okay. However, if you come home and you have to nap for the next 2 days, you've overdone it. And some of the signs of overuse which occur within the first 24 to 48 hours can include muscle cramping, muscle twitching, severe muscle pain, extreme exhaustion. And if that's the case, you need to first let your therapist know. Secondly, you need to pace your activities. One of the things you do have to be aware of, though, is if you've gone to therapy and you've done, say, an exercise program for your spine, and it's gone over very well, and you felt great, the pain was gone in your back, and you really had a great session, you left therapy and felt really, really good. Then you went to the grocery store, and you did your monthly shopping, and then you brought it all in the house, and you said, well, gee, now I'm feeling really good. I'll run to the pharmacy, then I'll go visit Aunt Edna, and you come home, and it's 9 o'clock at night, and you're exhausted the next day. Don't blame your therapist. Okay, look at your day. Okay, there are different types of exercise. There's the stretching exercise, strengthening exercises, conditioning, etc. And what I want to get into just briefly is stretching exercises help to increase muscle flexibility. Oftentimes with patients who have spine problems, they have very tight low back and hamstring muscles. On the other hand, people who have polio, especially if certain muscles were affected, have weakness and a lot of flexibility. Now, for example, if you have a very flexible hamstring and you lie on your back and you put your brace on by bringing your foot up and over your head, you do not need to stretch the hamstrings. They are over flexible. Please do, find that balance. Stretch what is tight, strengthen what is weak, as long as it's got the muscle grade to strengthen. Prolonged sitting, on the other hand of flexibility, and this was brought up very briefly. Prolonged sitting. Say you were a man and you walk most of your life as sorry. Most of your life you were up walking, and now you're spending more time in a scooter to get around. You're sitting a little bit more often. The muscles in the front of your hips, please demonstrate. The muscles in the front of the hip tend to get tight from sitting. Okay, so that will take you into an anterior pelvic tilt, okay, causing a low back lumbar lordosis, an increased lumbar lordosis. That in turn will make the muscles in the back of the spine tighter, and then will increase your low back pain. Okay, so just by adding too much sitting tightens the front of the hip muscles, increases the lumbar lordosis, tightens the low back muscles, increases pain. So that's where the stretching would come in handy. So stretch what's tight, but not what is weak and overly flexible. Getting into strengthening exercises, these are exercises that are performed with resistance, be it weights or stretch bands, or sometimes just your own body weight. In terms of, with spinal issues, oftentimes the core muscles are weak. Now, they tend to weaken with age anyway, and most people tend to get a little bit weaker in their abdominals, etc., but these are supportive muscles of the spine. When it's, complicated by a history of polio, again, be careful of the exercise guidelines when you're trying to strengthen. I do not advocate, crunches for abdominal strengthening. The abdominals are postural muscles. The crunches are a dynamic type of exercise. So I really work more on a stabilization program with the person lying supine. There's a core stabilization, trunk stabilization program. If you use two extremities at a time, two arms at one time against resistance can actually overflow to the trunk. There's a lot of very good exercise programs for core stabilization. If those muscles supporting the spine cannot be strengthened, say, these muscles are so weak that they cannot be strengthened safely and effectively, then, as was presented before, some type of an external support, a lumbosacral support or corset, can be utilized. It's most important when you're thinking about strengthening exercise, the most important thing is to strengthen with good technique, okay, good form, and less resistance than with resistance that is way too high for you, and then you're throwing your body into very poor technique. I belong to a gym. I go to the gym and I see these very tiny little women with their personal trainers, and they're pulling the, say, the lat pulls, and they have way too much, weight or resistance on. As they pull, their back is going back and forth, and I want to run up to them and stop them. But they would be better off dropping 20 pounds off of the weight resistance and pull with a good, strong technique, good form. So that's my talk about strengthening. Okay, conditioning. Endurance exercises, okay, we engage the large muscle groups over a long period of time. And muscles with good endurance are going to support our spine provide us postural stability throughout the day. They also help with cardiovascular endurance, etc. When the muscles fatigue, now the spine is subject to more biomechanical stress. You start hanging on your ligaments. At the end of the day, if you're here, okay, you're putting more stress on your spine. If the postural muscles can keep you up and you have the endurance of those muscles, you're able to support your spine and take stress off of it throughout the day. What? Yes, I can click you.
Okay, I wanted to discuss aquatic therapy, and Cynthia and I are both big proponents of aquatic therapy for patients with a history of polio. We call it the great equalizer. Things that cannot be done with the forces of gravity can oftentimes be accomplished very well in the water, and we get in the pool with our patients, and we do the exercise program side by side. Again, it's tailored with all the guidelines that Cynthia has already outlined. Many of you are familiar with it because it was often utilized in the recovery phase from acute polio, so it's familiar territory. It just allows a freedom of movement, and particularly for patients with spinal problems, the buoyancy unweights the spine, and it is great for pain relief because the compression forces of gravity have been alleviated. The buoyancy of water can support weak structures and allow for movement and decrease joint stress on the body. It also can provide resistance, depending on the way you're moving in the water. Water can facilitate a workout that can be tailored for each muscle group depending on your muscle test. One of the things that is often a deterrent is accessibility to pools, but now all public pools are required to have accessibility in the terms of a lift in and out of the pool. And Cynthia has been working with people at LA Fitness, and they have a great pool accessible. So many of the gyms in your area they're required now to have a lift. They have wonderful locker room facilities. Many women are concerned about getting the hair wet, and it's a big hassle, but most of our programs, you don't even have to get your hair wet. So some of the things that are big obstacles for people can be actually eliminated, and we're going to talk about some of the properties in the water. This is some examples of how you can strengthen, condition, and improve flexibility in the water. In the first slide, the patient sitting on a step and bicycling the lower extremities, which would not be able to be done on a regular bicycle. It can be done in a very slow, either range of motion type of activity, or it can be done more vigorously depending on this person's muscle test to see what they're allowed to do. When we were talking about trunk stabilization, the gentleman is moving the legs back and forth in the water, creating turbulence, which makes the balance become unstable, and yet the core is stabilizing those muscles, and he is working on balance in a safe environment. If he stumbles and falls in here, nobody's getting hurt. You know, you just get right back up and begin again. We can do many different maneuvers with the arms to affect the trunk in different ways. Positioning the feet differently will affect different muscles of the trunk and buttocks and legs. And then in the last slide, where the patient is on their back, this can be used for stretching of those hip flexors that Cynthia was chatting about. It can be used for endurance training by flutter kicking across the pool. It can be used for upper extremity range of motion and postural stretching. And if people are uncomfortable in the water, if they have an aversion, obviously we don't use it, but if they're just a little uncomfortable, we use flotation devices. We can use styrofoam noodles as resistance. We can use paddles for resistance. There's all kinds of techniques that are utilized to get better core strength around the spine in a safe and secure environment. The physical properties of water that affect pain relief and strengthening and conditioning, we discussed the buoyancy, that it provides support for weak limbs and less strain for the spine and the joints. Hydrostatic pressure in addition to the constant pressure being a pain reliever around the whole body because there's pressure of the water, it also can assist in a little bit of resisted breathing because of that pressure. In addition, it can help, the pressure is greater the deeper you are, so it acts as a compression for swollen feet and legs. So it has many, many benefits. Fluid resistance, we talked about. It's a perfect place for balance training. The force opposes the movement in the water, and the turbulence are even a micro-massage kind of effect, because as you're moving, it's mobilizing the tissue. So it's a very great environment for working with patients with a history of polio, I think. Okay.
Okay. I'm going to touch now upon body mechanics, which is a whole other aspect of physical therapy intervention. And body mechanics refers to the way that we move throughout the day, throughout our daily activities. Good body mechanics will help protect the back from pain and injury. It helps with our posture. And I guess the biggest take-home message I want to bring out here is that the way that you did things in the past may not be effective and safe now, with changes in your spine, with changes in your muscle strength due to a spinal diagnosis or due to aging with polio. So you need to take a look at the way that you're moving throughout the day and continue with proper body mechanics. Another very important issue with body mechanics is that if you do have a caregiver that helps you with transfers or helps you with bed mobility or helps you with any other type of ADLs, it's very important that they also use proper body mechanics to protect their spine from injury. Okay. Dr. Vandenakker covered the anatomy of the spine. The main thing here is that the good body mechanics and proper positioning will help protect the spine and alleviate some of the problems with the digestion, the swallowing, and the breathing. And posture, again, a very important aspect of spine protection, will be covered later today by Dr. Wise. So what are the guidelines of good body mechanics? And these are all listed, they're all in the handout. When you're standing, okay, wear shoes, keep the feet apart, shoulder width apart, the back straight, and if you get tired, lean against a wall or sit down, okay? Now again, all of these things are, in the perfect environment, in the perfect situation. For you, they may be a challenge, but take as much as you can from this and modify. Or when you're sitting, keep both buttocks sitting, on the chair, don't lean off to one side, etc. Okay. When you're walking, okay, keep the back straight, and a couple of the things that we see oftentimes with people who have spine problems and also people who have had polio, the hip abductors, the muscles on the side of the hip, may tend to be weak. If they are weak, they can put you into a Trendelenburg gait or a trunk shift, okay? If you're walking with that trunk shift, that will put an added stress and shear on your spine. So every step you take puts more stress on your spine. Oftentimes, something as simple as a straight cane can help to alleviate that trunk shift, okay, and help the weak hip abductors. The other thing that's very important is if there is a leg length discrepancy, okay, this also can exacerbate spine conditions, and your leg length discrepancy may change a little bit in terms of how your spine has changed, how you've been weight bearing, etc. So if you have a leg length discrepancy, make sure you get evaluated by an orthotist or by your physician for shoe lifts. You may not want to, and you will not want to correct 100%, but you will benefit. You may benefit from some orthotics to correct that discrepancy. And the last one that I just had this situation happen, I got a call from someone that I had seen about 2 years ago. She does have a scoliosis due to her polio, and it's progressing. And she used to be about 5'6". She's now about 5'3.5", 5'4", but was still walking on the same Lofstrand crutches, and they had not been adjusted to her new height. Okay, think about it. I mean, adjust your crutches or your walker or any assistive device to the height that you are now, not to the height that you were 3 years ago when you purchased them. Because if the crutches are way up here, they're not going to be doing you any help. So that's my third point about body mechanics and walking. Lifting, ask for help. Reachers, straps may be very helpful. Be aware of proper lifting techniques, which are probably difficult for many of us, but just try to be aware of them. Another situation I just saw, a woman using her one arm to reach down, grab her full leg brace at the lower end, and throw her foot up onto the foot pedal of her wheelchair. Okay, that was putting a lot of undue stress on one side of her neck, her spine, and her shoulders. Okay, when we switched her, the way she was picking her leg up, for her being aware of her posture while sitting and lifting her foot up onto the foot plate, it changed the situation dramatically. So very simple things like that can take a lot of stress off of your spine. When carrying an object, the rolling walkers with seats, the carts, they're wonderful. Put your, if you need to move your groceries, your laundry basket, or even your lunch tray, if you put it there, it can take a lot of stress off of your spine. Don't carry things that are too heavy for you. Keep them close to your body if you can carry them. Again, in sitting, I spoke briefly, use a small roll in your low back if needed. A supportive chair with armrest. Don't sit for long periods of time. Try to get up and move if at all possible, change positions. And also if there's any significant atrophy of the buttocks muscle on one side versus the other due to polio, you may want to put a wedge under that side so that when you're sitting, your pelvis is level and even. I've often, for many of my clients, and not only people who have polio, but anyone, I'll tell them to either, if they're on the computer, to put a little sticky up on the corner of the computer, and every 15 to 30 minutes, make sure that they change position and move. Because we can tend to sit at our computers for long, long periods of time. In the office, adjusting the computer monitor, using a headset or a phone speaker rather than holding the phone under your neck will help to alleviate some of the spine discomfort. Home modifications, this is a whole other aspect of physical therapy, intervention. Extensive home modifications can be extremely costly. One of my clients just redid her bathroom. It was about a $10,000 renovation. She got everything out, put in the toilet, the handicapped toilet. She put in a walk-in shower, and she said she needed to update her bathroom, and she said, I'm looking 10 years ahead. So she asked me to help her. I helped her draw up some plans. We met with the builder, and it's lovely, because now she doesn't have to worry about if she needs to use a walker or a wheelchair in the future to get into that bathroom. It's fully accessible. So in the bathroom, some of the things that you can think about: installing a raised toilet seat, a commode chair, grab bars, anti-slip mats, shower seats, handheld shower hose. All of those things can alleviate the stresses that you put on your spine. In the bedroom, I guess the biggest thing when you have spine problems, you may not be comfortable rolling, have difficulty rolling. You want to roll as a log so that your shoulder and your hip roll together, so that you're not twisting your spine as you're rolling in bed. This is very difficult to do on those pillow top beds. So usually a firm mattress makes it easier to roll, it makes it easier to get out of bed. Now there's so many options, the Sleep Number beds, where you can actually have a bed that's a little more cushy to sleep in, but not so soft that you're sinking, but you can make it very firm if you need to roll from side to side. There's also the adjustable bed frames, and that helps you to come up to sit, or if you need to elevate your legs. And they're not like the old hospital beds that were so uncomfortable. They're, you know, very nice and out on the market. There's a lot of them out there. The iComfort, the Select, whatever they're called, Sleep Numbers, all of those. And if you're lying on your side, if you put a pillow, a body pillow between your knees, it can help to keep your pelvis level, especially for women who have wider hips, instead of allowing the one knee to drop down and in and put a twist and a torsion on your spine all night. Some other things just briefly, in the kitchen, organize your kitchen. If you need to be getting to certain things all the time, put those at a height that's comfortable for you. Heavy pots and pans, leave them on the stove. When you buy new appliances, make sure that your controls are in the front so that you're not reaching way over and irritating your spine. In the living room, again, this is mainly supportive chairs with armrest. Stay away from those low, cushy, wonderful sofas that our bodies love to fall into. And the last one, when driving, okay? First thing I would like to recommend when you're driving is get into the car and look at your posture, okay? Then adjust your rearview mirror. So you get yourself up there nice and tall, you adjust your rearview mirror, and you adjust your side view mirrors. And as you're driving, if all of a sudden you can't see out of your back window, you can't see through your rearview mirror, it's not the time to adjust your mirror. It's the time to adjust your posture. Bring yourself back up again. It's a great type of biofeedback. As you're driving during the day, you know, don't readjust that mirror, adjust your posture. Use cruise control if you're going any distance. There's a lot of the cars now have heated seats, and it's wonderful, except if you live in Florida. But if you need some nice warmth on your back, it's a great way. You turn the heated seat on. And then if you are going long distances, make sure you get up and move. Take a stop every so often and get up and move and stretch your body. And again, all of these are listed, so hopefully you're not writing them down. Okay.
Okay. Well, in conclusion, basically what we wanted to say is to maintain the results that you do achieve in physical therapy, you just have to do some simple lifestyle modifications, a little bit of an exercise program that's realistic in your world, in your life, and then be adaptive to some of the changes, whether they're postural, biomechanical, and that improvements in spinal health and a general sense of well-being are very attainable and long-lasting. So thank you very much, and we will take questions.
I think we take just, we'll continue to stand down.
Okay.
Yes. One for you.
I lead a support group and have really worked in trying to get people interested in doing aquatic exercises. The biggest obstacle is the fact that the water's not warm enough. And that's true in the Wise pool and various other pools. We have found, you mentioned gyms, we have found certain hotels, especially if they have an indoor pool, it's warmer and we can go there for $5 or less.
Wonderful.
They oftentimes have policy set so that you just get a note from your doctor that you're not going to die if you get in the pool, and they do that.
That's a very good tip. Thank you.
The other thing that you may consider if you don't have access to a warmer pool is for snorkeling, scuba diving, they make skins, wetsuits that can be very helpful.
Can you talk about kyphosis?
What would you like to know about kyphosis?
Describe it.
So kyphosis is increase in the thoracic curve, so the forward curve in the spine between the neck and the low back. It can be so every spine has some degree of kyphosis in the thoracic area that can be exaggerated in certain spinal conditions. There's some congenital conditions that cause increased kyphosis. It also occurs when there are weak muscles in the back, and so the spine is collapsing forward. The muscles aren't able to pull the spine back up. Kyphosis is worsened when there are compression fractures, because the way the vertebral bodies compress are usually into an anterior wedge shape, so it exacerbates that kyphosis. And this is often progressive as we get older. It also gets worse with poor posture and sitting at a desk for long hours, and it's one of the things that can cause a lot of upper back and neck pain in people even without any sort of weakness, is because you're sitting at a desk all day doing this on the computer, and that when it's not related to structural changes within the spine, responds very nicely to physical therapy interventions.
I had lower back pain, and I went through everything you mentioned, the shots, physical therapy, but it got to a point where I wasn't even getting out of bed for most of the day. So they did an MRI, my stenosis became severe, and I had a Vandenakker-Albanese in October. I thought the surgery wasn't bad at all. Not that much pain at all, and immediate relief of my pain.
Yes, and so you were able to get by with a very small surgical procedure.
Yes.
And that is very individual. Sometimes people can be helped with a minor procedure and it's well worth going to surgery. Sometimes even having the big surgeries are worth it. But we certainly try all the conservative things first, because the highest risk intervention we have is surgery. So that's always sort of, if we can get you better with something less risky, we do it that way.
They did all that you said, though.
Good, you did it exactly right.
But you get to a point
And
where stenosis can be so bad that
definitely,
it's not a
right.
difficult operation.
Right. Well, and usually when people get to that point, the pain is so severe, they're like, I'll have the surgery. I don't care if it kills me. I need to do something. So,
I wanted to ask a question. I took calcium for many years because I have weak bones, and I took one of the medical supplements for many years. But there was a report came out that I saw in the newspaper somewhere that said that taking calcium was bad for the heart and increased heart attacks. I've never seen that since. Do you know anything about that?
I've not seen that since either, and I think it's interesting in our culture because the newspapers will report on medical studies in the literature, and you really, for physicians, there's a lot of studies that come out with conflicting reports, and you have to look at the quality of the study and how many patients they looked at, and you never get that in the news. And so the recommendations have not changed. That was not a high-powered study. But there are a lot of things we don't know, and I'll be honest, there's things we recommend, and then 10 years later we say, oh, never mind, But we're going by the best of our knowledge and what's out there. And I tend to approach it as kind of a more practical, or what seems more logical. So if something, I wouldn't take high doses of calcium, but depending on what your diet is like, if you don't get much calcium in your diet, taking a little bit of a supplement is probably safe. It's often everything in moderation. You remain in a pretty safe zone.
Can you talk a little bit about the neck and what happens when the pain goes to the traps and the scapular area and it's coming from the neck?
Yeah. I'm sorry. Her question was to talk a little bit about the neck and pain that radiates into the shoulder area. And there are several different things that can cause that. It can be from nerve impingement, but more commonly it's due to stress on the joints and soft tissue related to posture and positioning, as Cynthia was talking about. And especially positioning where your head is forward from your trunk and not balanced over the trunk, then the posterior muscles that support the spine and the head have to work extra hard. The further forward you get your head, which think of as a 10-pound bowling ball on the top of your spine, the harder those muscles have to work to keep it from just flopping down. And so if you're in a position where your head is forward all day, those muscles never get a break. When you're perfectly aligned, the muscles don't have to work very hard. They can rest. They're getting good circulation. If a muscle is tense all day, it's not getting good blood flow in there, and you can get a lot of then byproducts from that chronic contraction that cause increased pain and irritability in the soft tissues. But you also can have situations where the pain in that same area, radiating in that same area, can be due to degeneration in joints or sometimes impingement at some of the nerve levels. So it needs a good evaluation by a physician that knows spine, and then most of the time physical therapy would be the first course of treatment.
I've had it for 20 years, and fascinating. I actually emailed Dr. Weiss if you guys could talk about it. It's myofascial release, trigger point therapy, and good chiropractic. See?
Yes.
They say,
Mhm.
what I'm trying to understand is why and how. And
So you,
I'm so blessed. Again, I've got an amazing chiropractor.
good.
They've been using myofascial release and trigger point therapy. Went to frozen shoulder.
Right.
I'm trying to, you guys are helping me understand why.
So yeah, so her comment is that she's had this pain for 20 years, and there are often, because of weakness, because of the way your body is, you have areas that are a chronic problem that you're constantly fighting, and she's found a way to control it with myofascial release and trigger points, and that's exactly what you need to do. You need to find that balance, and there are many times with spine conditions we cannot eliminate the problem and we cannot make you pain-free. Oftentimes our goal is to just make it manageable or allow you techniques to alleviate the pain for periods of time. With a lot of the degenerative conditions in the spine, they aren't bad enough to do surgery, or surgery wouldn't really help, and they will continue to bother you when you do certain things or are in certain positions. And we have to kind of teach people to live with that, like you live with the limitations of polio.
If I could also comment on the, a little bit more on the muscular aspect, you need to get a good balance of your scapula stabilizers and get the lower traps strong enough so that the upper traps are not being overused during the day. So it's a balance between those muscles, and that's also a lot of posture, et cetera, but also strengthening the scapula stabilizers will make a big difference.
She's working real hard on that. This whole thing is fascinating.
Yeah. So when the scapular stabilizers are weak, the shoulders roll forward. That in turn brings the neck forward and puts more stress on the neck and muscles and joints. So yeah, it's all connected.
How often do you see these things in polio survivors that one side is just...
Oh, often.
They're very commonly, but you know what?
It's
I
everybody.
also see it
Yeah.
very, very commonly in non-polio survivors. I spend actually twice as much time treating people with spine conditions who didn't have polio as with my polio patients. So it's very, very common.
Can I add one more little bit to that?
Yeah.
I can. When your neck is forward and the muscles are trying, like she said, to keep you from falling forward, sometimes one side or the other will go into spasm, and that decreases blood flow to that area. So there's a buildup of the waste product of the muscle contraction, which creates like a burning sensation that the brain can perceive as further injury or trauma. So it says, recruit more forces to stabilize the area, and then the spasm can actually move to other areas, and the body's thinking it's doing a great job by tightening and putting on its own little support, but in essence, until you get in there, like we've talked about, and improve the blood flow, normalize the balance of the front to the back, create that homeostasis in the system, you can't break the cycle. It's a pain spasm cycle that keeps perpetuating.
Yeah.
There you go.
So we have a question in the back.
My husband had polio as a child, leaving his legs paralyzed and affecting his left shoulder. In about 2002, he was diagnosed with osteoporosis and was on Fosamax, probably with one brief break for the until just recently. He wanted to know what other medications were available for treating osteoporosis other than Fosamax, and also what range of calcium and vitamin D he should be taking.
So rule of thumb, the calcium is requirement for an adult is 1,500 milligrams a day, with I think it's 400 or 800 international units of the vitamin D, depending on what he gets. Actually, the vitamin D may be higher now that vitamin D is the thing and everybody is deficient. So probably his primary doc would recommend more vitamin D because usually people need a little bit extra. There are other medications for treating osteoporosis. We don't really have time to go into all of them, but there are a variety of medications available. His primary doctor should be able to help with that. No? Then you need a different primary doc. Gotcha.
There is the blood test now that they do for vitamin D levels.
Yes, they do.
They're efficient in it. Now, if your vitamin Ds are low, it also causes muscle pain.
Exactly. So,
The actress immediately tested mine when I was having more muscle pain to see if I had dropped.
right. So the vitamin D level can be tested with a blood test, and that'll determine what the dose of the vitamin D should be, because if it's low, then you get extra for a while till it brings you up to normal levels. Nancy?
Is a TENS unit used for nerve stimulation or muscle stimulation or both?
Well, for pain control, it's nerve stimulation, and is how we use it in the polio population, because we don't want to stimulate the muscle contraction and over fatigue those muscle fibers.
I heard you say that. That's why I wasn't sure. My physical therapist has used it on me for a variety of reasons, and it really hasn't helped much. And I just don't understand whether it's for nerve stimulus or muscle.
Well, if you've had a good trial of it and it's not effective in your case, then I would move on to another treatment modality. You know, there's no sense doing the same thing over and over if it's not effective for you.
Maureen, you're going to be the last one because I think we're over time.
I just wanted to know what your opinion is of having your neck and spine adjusted for a polio survivor from a chiropractor.
So Maureen wants to know what we think. Yes, I know, Joan, thank you. About chiropractic treatment for a polio survivor. I think it can be very helpful for alleviating asymmetries in the muscle contracture and pressure points. The chiropractor, of course, has to know something about polio, has to know if you have osteoporosis. In general, you will not want high velocity manipulations, but if they are doing the low velocity and modalities, it can be very helpful. And thank you, we're out of time.